welcome everybody, and back to the final panel of the Student Psychedelic Conference 2022. So this panel is titled Psychedelics and Pain, and it's one which I've really been looking forward to. I'm sure it'll be very interesting. We have a nice spread of different panelists here who will give 3 presentations, followed by about half an hour, maybe 25 minutes of question and answer. If we run a little bit over, that's okay. And first up, we will have Joanna Kempner, who is an associate professor of sociology at Rutgers University in the USA. She has worked with cluster busters who have backed research for cluster headaches, including research into psilocybin. And she'll be sharing an update about patient-led research in the underground and its role in the psychedelic renaissance, part of her soon-to-be-released book, Psychedelic Outlaws. Following her will be James Close and Julia Bornemann, who are both PhD candidates at Imperial College London's Centre for Psychedelic Research. James studies the interface between physical and mental health and has a background in physiotherapy, while Julia has a background in neuroscience and has been involved in several psychedelic trials at Imperial. Together, their current work focuses on public involvement in research, the potential role of psychedelic drugs in pain management, and the mechanisms of psilocybin in chronic pain conditions such as fibromyalgia. Following them, we'll have Jan Ramaekers, who's a professor of psychopharmacology at Maastricht University in the Netherlands. His research uses a multidisciplinary approach to determine drug-induced changes in human performance. He'll be discussing how low doses of LSD or other psychedelics could be applied as analgesics. And following this, we'll have about half an hour of Q&A, maybe 25 minutes. If you need a little more time, feel free. That's enough of me. So on to you, Joanna. Thank you very much.
Thank you so much for inviting me here. I'm so glad that you have a panel on psychedelics and pain. It's so often overlooked in these conversations. So I'm a sociologist rather than an MD or psychology. So a little bit different than most of the experts that people usually hear from in this world. And I've been conducting an ethnography of cluster busters, which is a patient-led movement that has largely been responsible for developing psilocybin as a therapy in cluster headache. And writing a book about that. I've been writing some articles about that as well, which you'll be seeing. So people mobilize and develop treatments when institutionalized medicine fails to provide effective treatment for them. And there's a long history of people organizing in this regard. These are just a few examples. I apologize, they're all American examples, but when HIV/AIDS emerges as a pandemic, you see the gay rights movement doing this, the women's health movement. In the United States, we had underground abortion services, and we probably have them again. And the environmental health movement are just some other examples. Cluster headache is much the same. So many people aren't really familiar with cluster headache. And even when you are familiar with cluster headache, it's really hard to kind of wrap your head around how serious this is. Headache isn't really a term that provides sufficient weight to this problem. So people with cluster headache, and sorry, pressing the wrong button here. It's a disease that is uncommon, but it's about as common as multiple sclerosis. They describe that pain of unimaginable intensity. It comes on quickly, first as a pressure building on one side of the head, and then as a hot iron, like a hot iron blade kind of jamming into their eye. And then kind of as in sympathy, they get all of these associated symptoms. Their face droops, their eyelid swells, the eye and their nose release a waterfall of tears and snot. And then what happens is it's often accompanied by restlessness or agitation. People with cluster headache kind of describe it when your thumb gets stuck, jammed in a car and you're like kind of doing this, but it's like their whole body's doing it. They'll rock their pace. They repeatedly slam hard objects against a door jamb or against their head, sometimes trying to knock themselves unconscious. And the headache, the cluster in the headache is temporal. So people will get up to 8 attacks a day. The attacks are short, 15 to 180 minutes. And then when they end, it's almost as though nothing has happened. People are usually episodic, meaning these attacks occur for 2 weeks to 3 months at a time. A minority of people are chronic, meaning they have no remission. Now, how bad can a headache be? Medical reports document one person with cluster headache trying to shoot the pain out of their eye. They survived. Another attempted to resolve their pain by scooping their eyeball out of their head with a spoon. Suicidal ideation during cluster headache is very common during cycles. It's about 70% of people with cluster headache report imagining suicide just to kind of stop the pain. This is very, very severe pain, the worst pain that imaginable according to most reports. But treatment is very hard to find. And so if you Google cluster headache treatment, one of the first things you'll find is cluster headache treatment at home. And when that comes up, you'll probably find the cluster buster method, which is an online protocol for how to treat yourself using low doses of psilocybin that you grow using yourself generally. These are sometimes sub-hallucinogenic, but they can, the doses can go up to just sort of kind of low hallucinogenic doses. The book that I'm writing is about how the people with cluster headache developed this treatment. It's a fascinating story. It starts with a person in Scotland named Craig Adams, who realizes that his recreational dosing with LSD have prevented his cluster headache cycles, and through research and self-experimentation figures out exactly how to do this. With the rise of the internet, he's able to spread the word, and in 1998 tells other people with cluster headache online that he says he's using small doses of LSD, but what he's really doing is using Liberty Cap mushrooms. He convinces other people online to do it. And doing research, they realize that psychedelics and headache medicines have a long intellectual history, which I won't go into now for time's sake. One of the most convincing things to them is the discovery that serotonin has an indole ring, as does psilocybin and sumatriptan. And this, of course, is something that many of you will already be familiar with. It's something that strikes a lot of neuroscientists as well. They engage in a series of self-experiments, which they do collectively on the internet. It's something that I've written about. It's a fascinating kind of set of experiments they do, and they develop a protocol for how to use psilocybin. The first protocol is published in 2004, as opposed to the protocol that I I showed up in the beginning of my talk. So this has been publicly circulating for a long time. And some of you may be familiar with a 2006 neurology paper, a peer-reviewed article called Responsive Cluster Headache to Psilocybin and LSD. This is a case series done with authors from Harvard. And essentially, it's not said that this is true in the article, but this research is all culled from the Cluster Busters case studies. So this is a case where the researchers at Harvard take the data from the patient-led movement, kind of fill in any missing data, and then publish it as their own and legitimate it as above ground knowledge. There are a number of other articles about the use of psilocybin and its efficacy that Cluster Busters then facilitates over, the next 15 years. And that has now culminated in a clinical trial at Yale, which is just wrapping up. We'll see the results very shortly. One of the most interesting things to me about this clinical trial is that the PI for this clinical trial, Dr. Emanuel Schindler, is very open that the protocol that she's using on this clinical trial that she had adopted straight from this patient-led movement. So this is something that she says in an article about this treatment in the Washington Post. Schindler not only relied on Cluster Busters to recruit patients for her study, but also used key parts of their dosing protocol. And they go on to say, after years of self-experiments, many group members believe they have shortened or busted their clusters with 3 sub-hallucinogenic amounts of mushrooms spaced 5 days apart. Schindler's doing the same thing using synthetic psilocybin. And she said she expects her results to show that, quote, patients know a lot more about their condition and how to treat it than they're usually given credit for. So I was told to keep this really short, and there is so much to unpack about this story and what it tells us about drug development in general. But it's what I want to just sort of broadly say, and the message I kind of want to broadly give all of you, is first that this question, like how do people in the underground, in this case, patients, citizen scientists, how do they create a standardized protocol from mushrooms? How did they do that? Because a lot of the treatments that we're dealing with now come from people in the underground, right? And I should say that they drew upon a considerable amount of research that they found from pre-1970, because there was a considerable amount of research out there already on the use of psychedelics and pain. The second thing that I think is really interesting here is what their story tells us about drug laws generally, and what it means that people have to break the law in order to get treatment for their pain condition. Because the people who are in this group are not people who had ever really taken psychedelics before. They're not people who wanted to take psychedelics. They weren't people who came to a drug culture easily. So what does their story tell us about drug laws and the rise of psychedelic medicine more generally? And then the third piece of this is who are experts, who gains credit, and who eventually will gain access to these therapies. So those are the big questions that I'm interested in. And then I think for the purposes of this particular discussion that we're having here, I think there's also a broader question that I think Clusterbusters is really dealing with now, which is how do we get this question about psychedelics and pain more air generally, given how much of the discussion around psychedelics has been around mental health and behavioral health, because that's a kind of another thing that they've been talking about. So I'll leave it there. Thank you so much. You can follow along as my work is being published or on Twitter. And that's it.
It's absolutely brilliant. Thank you so much, Joanna. Great to hear about this historic perspective of Clusterbusters and how it really came to be, and how important it is to consult patients in saying that they often have more knowledge about their condition than they're given credit for. So I think James and Julia might touch on a similar topic here. So I'll give the floor to both of you.
Thanks so much.
How's that? Can you see the slides okay?
I can see them just fine.
Fantastic.
Great. James, you want to start?
Yeah, I suppose we'd start by introducing ourselves. My name's James Close. I am a physiotherapist by background. I still practice as a physiotherapist and work in a tertiary care pain management unit in West London, where we treat all sorts of chronic pain conditions, including fibromyalgia, which is something we've got a particular focus on at the moment.
Yeah, and my name is Julia Bornemann. I'm also a PhD candidate at the Center for Psychedelic Research. And I have been for the past about 2 years setting up this trial, or the study rather, that we have that we're just starting to recruit now for, which is specifically looking at people with fibromyalgia. So this has been a long time coming, and we'd love to tell you about how we started thinking about it. So James is going to have the slides up, but I'll just be speaking, so I apologize if I say next slide, please, at some point. Anyway, so the study that we're working on, as I just said, is called PsiloPain, and this specifically investigates psilocybin in a chronic pain fibromyalgia population. So for those of you who don't know, fibromyalgia produces widespread pain all over the body. And this causes serious impairment and also has significant mental health impact for a lot of people. So the aim of the study is to learn about the central mechanisms going on here with psilocybin therapy in the brain and psychologically. So we're going to be using a mix of neurophysiological techniques, so EEG and MRI, but we're also looking at psychological, behavioral, and qualitative outcomes as well. And as part of the study design, or throughout the study actually, we're using what we are calling PPI, or patient and public involvement. So this is directly piggybacking off of what Joanna so beautifully described earlier. And the basic tenet of this concept is basically doing research with rather than on people. So it's moving from a place of objectification towards equality in research. So this includes people with all sorts of lived experience, so patients and carers, but also lay people, community members, and PPI experts. And it produces really efficient and cost-effective outcomes, but it also improves how people feel in the long term, because it nurtures trust, and yeah, people are more likely to comply with their recommendations as well. So for us in our study, we used a number of PPI methods to inform how we will conduct our research. So I'll tell you about a few of them. We did some in-depth discussions, some focus groups, and we also utilized a really fantastic range of expert advisors to inform our hypothesis building, our protocol design, patient communication, such as with patient information sheets, but also really directly in the therapeutic intervention itself. And I'm just going to start with a paper that I published last year, or we all published together last year, looking at people directly who self-medicate with psychedelic drugs, who have chronic pain. So James did perfect. So this is an example of how we basically wanted to inform the study design. So we have a limited background research on psychedelics and pain, and this typically involved in the 60s and 70s. It involved non-standardized protocols, which weren't particularly helpful for us when we were trying to build a study. So we didn't really have a clear place to start with study design, but we figured that instead of trying to reinvent the wheel, it would be fantastic to tap into these resources which exist online of support groups, but also of people publishing how they have been using these substances and what works for them. So we wanted to harness the knowledge of people with lived experience to influence our trial. So the aim of this project was to find out what is important for people who have self-medicated with these substances in their experience of chronic pain, and how could this help us to improve our protocol. And we had 11 one-hour discussions with people who self-medicated with chronic or for chronic pain. And the interviews were transcribed and thematically analyzed for major themes, which you can see on the right here. Some of them were quite standard for psychedelic research. So for example, being trusting and open and including, focus on the breath and mindfulness. But then there were some other, really interesting, more pain-specific things. For example, including movement like yoga and qigong, which we have to consider, or we had to consider for our protocol, but also influenced some new research directions, actually. So we're now investigating the physical processing aspect and embodiment as serious questions in our trial, which were raised directly from our discussions. So we found it really fruitful, not only in the design, but also in hypothesis generation, in the kind of the front part of the study. So now that we're starting, it's going to be really exciting to see how that develops. And James is going to tell you a little bit about the other ways that we've used patient involvement now.
Lovely, thank you, Julia. Yeah, so we really drew on a huge range of experience to try and inform our study protocol and our study manual, and we're still sort of processing all of this information at the moment. I think the main thing to recognize here is that there's very little precedent set for research in this area of chronic pain. And we really wanted to sort of recognize that this was a condition that it's a disease in its own right, and we wanted to treat it as such rather than sort of assume that all the same processes in the dosing sessions would happen the same way as with, say, for example, patients with depression. And so, yeah, we wanted to draw on all the experience and really carrying on from what Joanna was saying and all the great work that cluster busters do as in putting patients as experts at the center of this. It's a really important philosophy that we've had, and it's proved really important. So we used ex participants from other trials, including sort of the depression trials, to understand their experiences, as well as sort of patient advocate groups and the patients themselves and their carers, various underground guides, and of course, sort of clinical psychologists specializing in pain. And we did one-to-one interviews. We had some nice conversations together. We held various workshops. And as we were doing all of this, we realized that actually there was no real guidance or roadmap for how to involve people from outside our research group. And so we made some rules with the help of patients themselves. And we put it into a publication here last year, or a couple of years ago now, called Co-Design of Guidance for Patient Public Involvement in Psychedelic Research. And sort of we've really tried to summarize and consolidate all of the useful advice and information that we've got in doing this process of learning from lived experience. And we're putting it into action now with our chronic pain trial as well. So that's an open access paper. You know, sort of very briefly, we really identified these key foundations so important in psychedelic research and psychedelic treatments in general, of, you know, building on trust, shared learning between the journeyers and the people going through the process, making inclusivity a real priority here and trying to diversify as much as possible, and really creating a very clear purpose throughout everything we were doing. Yeah, and so we're still going through we're still doing this now. We're still learning. You know, we've created this guidance, but we'll go back and review it after we've finished and try and understand how useful it's been. Yeah, so sort of in summary, really, using so far, really using patients with fibromyalgia and chronic pain to help us develop our research is hopefully going to create a more effective, relevant process for people that can be applicable outside of this trial. You know, we've tried to make it tailored to people with physical pain, and we want to try and improve our retention throughout the trial as well. Yeah, and as Julia said, really trying to understand the experience of people going through this process is a really important part of creating new research and creating hypotheses for future research as well. And hopefully it will impact the relevance to people with pain further down the line. But we haven't started yet. We're going to start very soon. And so time will tell. Thank you.
It's wonderful, Julia and James. Thank you so much for the nice talk. It's great to hear of the patient public involvement and things going on in Imperial currently. So it's a real necessary part in something that's so subjective like pain. The psychedelic experience is subjective, of course, but pain conditions like this affect different people in different ways. So that's great. Next up, we have Jan Ramaekers, who will be presenting on the low doses of LSD as an analgesic paper released last year. So if you'd like to share your slides and go on with that, Jan, that would be great. Thank you.
Thank you very much, Eden, for the introduction. Can you see my slides? Okay, great. So welcome everybody to this short lecture. I will be presenting some data that we collected about 2 years ago. Well, we published it actually 2 years ago, where we conducted a study in healthy volunteers to see if there's any analgesic potential in the use of a psychedelic, and in this case, LSD. And we were, of course, very much inspired by some of the earlier work that was conducted in the 60s and the 70s. Maybe this has already been discussed even tonight, but there are a few landmark studies that are worthwhile reading when interested in the topic of psychedelics and pain, for sure. And a short summary is that people who were terminally ill, for example, who were suffering from cancer, had been treated with high doses of LSD. And the main finding of these studies was that a high dose actually produced analgesic effects, reduced pain in these patients, and not just on the day that they were receiving a treatment, but actually for a couple of days, and in some cases even weeks. So that was the first indication that perhaps psychedelics can be useful to treat pain. But in some of these patients, when they were asked whether they would like to have a second dose, they would actually say, no, this is not for me, because they didn't really like the perceptual part of the psychedelic experience that much. So they rather choose to bear the pain than go into a full-blown psychedelic experience. And that actually made us think whether it would be possible to repeat some of these findings, but then with lower doses that would not actually produce these perceptual effects. And if that were the case, then perhaps it would also be more clinically feasible to use LSD or other psychedelic compounds in a clinical context. And since the 70s, there haven't been any controlled studies with psychedelics in the context of pain treatment. But there have been quite a lot of surveys that came out, and Julia and James covered some of those already. We also did a survey that is not yet published, but basically also inquiring among pain patients who are using or treating themselves with psychedelics, what the efficacy of this actually is. And when they compared their treatment with high doses or low doses of psychedelics, they rate the pain relief higher as compared to the conventional medications that are currently on the market to treat pain. So think about opioids primarily. So we set out to begin a study in healthy volunteers, and the first problem really that we had was, what is a microdose? What is a low dose? And where do the perceptual effects actually start with LSD? And although there's some literature on that, we thought that it might be a good idea to actually set up a dose effects study where we treated healthy volunteers with placebo, but also with low doses of 5, 10, and 20 micrograms of LSD. And we would then follow them on each of these test days for about 8 hours and have a number of tests that we were interested in. So in this study, we not only looked at pain, but also at other interesting perspectives like positive mood or attention, neuroplasticity. But for this presentation, I will focus on pain. And the way we try to measure the analgesic effect or the potential analgesic effect is to induce pain in our healthy volunteers using the cold pressor test, which is a very simple test in which participants were asked to put their hand in a cold bucket of water that is kept cold with ice at about 3 to 4 degrees Celsius. And of course, that's quite painful if you keep your hand in that water for a prolonged time. And in this test, the maximal time that you are allowed to keep it in there is 3 minutes. But most participants actually won't last up until 3 minutes and will retract their hand much earlier. So this offers the opportunity to measure the time that people keep their hand underwater as an objective measure of endurance of pain. But we also asked participants questions afterwards on how how intense the pain was, how stressful the entire experience was, to get also a subjective indication of how pain was felt. So the data are presented here. So on the left panel, upper panel, you see pain tolerance expressed in the number of seconds that participants were able to keep their hands in the water. And when you conduct statistics on these findings, typically you do not see any change for the 5 microgram, the 10 microgram dose relative to the placebo. So these are the bars here. So not at 1.5 hours and neither at 5 hours after administration, but at the highest dose that we administered, so 20 micrograms of LSD, there we did see that the time that participants were able to keep their hand in the water actually increased, both at 1.5 hours after dosing and also 5 hours after dosing. And these objective findings were supported by the fact that participants reported that the feeling was less unpleasant, it was less painful, and also less stressful, although the latter did not reach statistical significance. So this is a good indication that there is an analgesic potential in LSD, even at lower doses, that might be interesting to follow up on. But of course, one of our aims was to show that this effect can occur at a dose that does not produce any noticeable psychedelic effects. And therefore, we also had subjective questionnaires included in the study where we looked at some of these psychiatric effects and drug effects in general. And with the highest dose, and you can see that in upper panels, people did report that they felt a little bit high and felt a little bit under the influence, and also ratings of anxiety and derealization, for example, increase a bit. But this is not the full score that you're looking at here on the y-axis, but it does indicate that participants did notice that they used a dose of LSD. But at the same time, I think it's also fair to say that had there been neutral people walking into the experimental rooms and look at our participants, they would not have known or recognized that these people were actually under the influence at all. And also, when under the influence of 20 micrograms, people could actually, sit behind their computer, do their work, whatever they wanted to do. So it's noticeable, but it does not really interfere with your day-to-day operations at a low dose like this. One aspect that we were quite interested in was blood pressure, because we have to think about what it actually means, right? That we find this analgesic effect in terms of what is the mechanism and what is the cause. And there are potentially 3 explanations that we could think of. One is that, given that there is still some psychedelic effect measurable, perhaps that attracts attention and pulls it away from the attention that you would normally focus on your pain. So that could be a mechanism. Another mechanism might be just pure pharmacological, because we do know that LSD is an agonist of 5-HT2 and 5-HT1 receptors, and they are located in the dorsal raphe nucleus. That provides that stimulates descending pain inhibitory processes. So that might be the pharmacological effect. And a third effect that we were interested in, or mechanism, is really the relationship between blood pressure and pain, because it's known from the literature that with increasing blood pressure, that actually induces hypoalgesia. So we looked at the systolic blood pressure and the diastolic blood pressure, which actually increased a bit after most of these doses of LSD, but not to a degree that it was in any way worrisome. So they did increase, but it stayed well within the normal range. But the increase in blood pressure was actually correlated with the analgesic effect that we measured in the cold pressure test. And it explained about 14% of the total variance, whereas the perceptual effects only explained about 4% of the variance. So 2 out of these 3 explanations we could basically test on our data, and the data indicate that it may actually both contribute a bit to the end effect, but of course the pharmacological effect we couldn't really check in our data because we have no brain data on the stimulation of the 5-HT2 receptor in this particular study. So, and that brings me to the last slide. So it's an interesting finding, absolutely, but at the same time, it's the first and therefore it needs replication with LSD or other compounds, and also perhaps at doses that might be a bit higher than 20 micrograms, perhaps up to 50 even. An issue that may arise is tolerance. We know this does occur with LSD. So what happens to this analgesic effects if people start taking a low dose on a daily basis or every 3 days? Does tolerance develop? And of course, we found our results in healthy volunteer population, and that does not necessarily mean that you can find the same in patient population. So we need to move to patients to be able to generalize these findings to the clinical population as such. And then in the end, there's this question of feasibility. So let's assume that this works perfect, not just for LSD, but any other compounds. So how would that then work in clinical practice? If somebody goes to the doctor and would he give him a strip of LSD, of low doses of LSD? Then how do we make sure that people are not going to use it, put it all together and take high doses? So how can you control basically the dose that people are taking at home when you give them a strip of LSD? But these are all future problems, and in the short term, I think it's most important to actually replicate these findings, primarily also in patients. And with that, thank you very much.
Lovely. Thank you very much, Sean. Good to see the background of this research a little bit more, and especially things in terms of replication and whatnot. So we've managed to run a little bit over. That's okay. It's no problem. Still have maybe 25 minutes for some question and answer. And there has been some quite nice questions coming in. So thank you to the participants for asking those. One of the questions, first one that caught my eye, are there using psychedelics in cluster headaches, is it usually used during acute episodes or as a preventative measure?
Both, actually. It's preferred to use it preventively, obviously. Nobody wants to have a cluster headache, but people use it to break their cycles as well. And in the clinical trial, I believe that people have to be in cycle to be tested in that clinical trial. So the clinical trial is testing its ability to stop a cycle. But in the group, they teach you how to use it preventively. The cycles tend to be circannual, so people can often predict when their cycles are happening, and then they can what they call busting. They can dose a few weeks in advance of when they think their cycle will occur.
Okay, maybe outside of cluster headaches for other chronic pain conditions, this is being directed towards James and Julia. Do you know if that application would be long lasting, if there's been any type of animal models, for example, or things of estimates of how that effect might work?
It's difficult, as always, to translate animal models, but from the data that we do have, it is largely quite old, and the methods are a little bit inconsistent, so I'm hesitant to comment on any of that. But just from the more obviously small sample size, but of the people that I've spoken to in the publication that we mentioned, and also from the PPI work that we've done, it seems that the effects are not long lasting in the sense of the depression effect. So it's not going to last for months, at least for the vast majority of people. There might be a kind of a short amount of analgesia, as is supported by the evidence that Jan just presented, but I don't think that it's a silver bullet. I don't know if you guys want to add to that.
Yeah, I mean, I just look at, if you read Julie's paper, which looked at 11 patients who self-medicate with psychedelics, there's a whole sort of variation in responses. I mean, obviously the big limitation here is that they're all self-selecting. So these are people who have presented themselves to us. You know, I self-medicate with psychedelics successfully. This is how I respond. So that excludes obviously all the people with pain who maybe have psychedelics and don't notice any changes at all. So I guess that the short answer is we just don't know yet. But you just need to look at cluster busters to see how, you know, to see all the stories of potentially, you know, anecdotal evidence, of course, of really long-lasting improvements. But again, it's not something we have observed yet, really, under laboratory conditions. Yeah.
I think also you'd have to point out that there are vastly different mechanisms for different types. So one person was asking about neuropathic pain in the questions, for example, which is entirely different from cluster headache pain. So these will obviously have very different effects. Sorry to cut you off, Jan.
No, not at all.
Yeah, so I don't know. Yeah, I don't have a better answer, but it is intriguing that even with pain, there is usually also a kind of an affective disorder associated to it. There is an affective component to it, and I think that part, the affective part, might actually be treated with psychedelics, maybe even more successfully than the neurological part, if you know, but we don't really know what the cause is. But this is something that I do pick up, at least among patients themselves. So in that respect, I'm a little bit optimistic, but I think I tend to agree with Julia that I don't expect that, certainly not with low doses, that they will keep, you know, that they will suppress the pain for months and months to come. I think that would be overly optimistic. I think we might be very pleased already if you find a dose low enough that will allow people to do their day-to-day operations while suppressing or controlling their pains. I think that would already be success. And if we could find a regimen that is also good enough, maybe to be personalized, so that there's almost like a range in which people can self-select a dose that works for them, and also a frequency that is infrequent enough to not develop tolerance, so that so that I think that might be feasible, but it needs a lot of work and research. But that's how I look at it, at least.
Okay, so I'd understand it's only during the effect of the drug itself rather than some sort of afterglow.
I think there might be like a very slight, very tiny afterglow, but I'm hesitant to say anything.
Okay, understood. Well, another question for Jan in that case, that the others you might like to chime in on also. I'd heard before of this idea of intention reorientating, where during this time where they have a low dose of a psychedelic or even a macro dose, a larger dose, the attention is taken away from the pain.
Yeah.
Would that be perhaps something that would support the mechanism of the pain suppression, or would that have a larger role to play, do you think?
I think it can play a role in many individuals that are suffering from pain, and I think it might even be a mechanism, even if the contribution as such may not be very big. You could sort of work with it or try to increase its contribution to the analgesic effect. Pain patients, you try to look for ways to reduce their pain by, I don't know, doing yoga, meditation, all these kinds of things to sort of control how they psychologically cope with pain. And one of the things that we are, for example, interested in is things like hypnotherapy, right? That's also basically trying to steer the attention away from the pain that people are feeling. And I could imagine that you do that in combination with particularly a low dose of LSD that might actually boost the effects of a low dose. When they are minimal, it might actually boost those effects a little bit. So I think you can try and look at several means to sort of get an optimal effect of your low dose LSD or whatever psychedelic treatment.
Nice, thank you for your answer. There's another question in the Q&A box of asking if BMI is taken into consideration when determining dosage. This could go for LSD low doses and analgesic, or other compounds used for cluster headaches and otherwise, or is the dose the same, so to speak, per indication or body type?
That's a very good point. We did not adjust for body weight in this study. We have done it for many other studies with psychedelics. And it's typically something that you do in an experimental setting where you want to make sure that everybody gets relatively the same dose that may lead to the same drug concentration in plasma. But that's not how it would work in clinical practice, I guess. But what I do think is that in the clinical practice, you should have, and I mentioned that before, maybe have access to a dose range that you can play around with, because everybody differs in their sensitivity, to drugs in general and also psychedelics. So maybe it suffices for somebody to take 5 micrograms, the other one needs 10, and the other one needs 20. That's difficult to say.
I suppose in determining that, it would be back to the patient-public involvement.
Yeah.
Like James and Julia have spoken about. I have a question, another one here for Joanna, which I think is quite interesting. It asked if there's any concern that people under an intense amount of pain might have a higher likelihood of an adverse psychological effect to a psychedelic than a healthy, normal cohort.
The Cluster Busters does a pretty good job of specifying safety considerations, but of course it is decentralized. And people with cluster headache, they believe there's some data now too, and of course this is all again initiated by the patients themselves, thought to have a higher levels of PTSD. But the suicidal ideation is high because the pain is high. So no, I mean, I think what's interesting about what Jan is saying and pointing out this this in the CAST articles, I hadn't really thought about this before, is the people in the cluster headache groups and the forums, you can see a lot of people really hate those high doses. They try and avoid them. So there's been a lot of work to see what the minimal dose could be for people to get treated. And there's a lot of advice in those forums about what kind of like how to reduce anxiety, how to reduce just what to do in case of a so-called bad trip. And there's a lot of mutual aid and support. So I haven't really heard of anybody having particularly terrible effects, to be honest. It's not something that comes out. I mean, I have millions of pages of data up on this forum, and that's not really something that I'm seeing.
I'm sorry, thank you. Yeah, it's something I've heard discussed before of how patients themselves, when using psilocybin, for example, for cluster headaches, they often ride out the trip, that they might take the dose and try and sit it out to get the effect, but rather than enjoying the experience in any way, it's almost a burden. Maybe if things go forward in the future, the non-psychoactive psychedelics, so to speak, might be able to have some influence there. But do you have a point, Joanna?
Yeah, well, the other thing is the busting protocol is intense, right? You have to do it a couple times. And nobody, like, people don't have time for that. Like, they have kids, they have a life. Like, it's not something that people want to do. So people are always kind of like trying to minimize that effect on their lives. And they're already quite worried if they're going to have a cluster attack in the middle of it. So I think people aren't really going for big trips anyway. And if they are, they have already built in like so many supports. I think that if people were having like really, really bad psychological effects, it would have come out in these forums, right? And I'm not seeing that.
Yeah, so people are generally using quite low doses. Yeah. Okay, makes sense. There's another question that's quite nice. It's asking about biomarkers of pain, particularly in regards to inflammation, and if any of the pain measures currently used in clinical trials, or be it questionnaires or otherwise, if a biomarker might be more suitable to measure this pain. If anybody would like to take a shot at that one.
It's a very challenging question. So I'm not aware of a biomarker of pain as such, but what we can do in upcoming studies is try to find biomarkers of the psychedelic induced response. Right, there's clear evidence that psychedelics can treat inflammation processes, for example, and you can actually measure in blood some of the biomarkers like IL-6 or TNF-alpha. And that's interesting to follow and to measure, and also to associate with the analgesic response. Once you can make that connection, even though it's just a correlation, then that might actually be take the role as a biomarker of the analgesic effects, if you can demonstrate the association. So that is something that people are working on, and that potentially is could be successful, I think.
Yeah,
sorry, I'm not. No, I say, like, I'm not, again, like, I'm not a biologist, but I'm a sociologist of technology, and so there's quite a lot of work on coming up with a pain thermometer, which would be quite useful in terms of biomedical studies. My skepticism here is in the potential ethical issues and problems around equity. I'm not sure that is actually possible or preferable to have a so-called objective marker of pain. I'm not entirely convinced that that kind of marker wouldn't underestimate the same kind of the pain of the same kind of population. So that inequity wouldn't be already built into that measure. That would be my concern. So.
Yeah, true. It may not be directly related to the level of inflammation, or it might even be the anti-inflammatory property of the psychedelic that's making the analgesic response. It's exciting to think how these things might come out in research going forward.
We don't have a lot of clinical research done on marginalized populations. So if the research on pain thermometers excludes populations that we're already not paying attention to, I would like to see the biomarker that is inclusive of those populations, is what I would say. So I'm not hugely excited about that biomarker's emergence.
Yeah, it's real world reliability might not be the best if that's what it goes on. Sorry, James.
It's a long-standing challenge in the field of pain research in finding a biomarker for something which is inherently subjective, and there's been lots of sort of progress made sort of over the years, but still it's very arguable whether even some of the sort of brain data that's come out of sort of the MRI studies identifying sort of a pain matrix, so to speak, in the brain that's associated with pain, even that sort of is questionable, but we're edging ever closer.
Yeah, good. I have some more questions here. I think we'll finish up at about 6:30, so maybe another 5 minutes or so. There is some questions from Alex in the Q&A box, who is a consultant rheumatologist. And he asked you, to James and Julia, do you take into account conditions which are mimics of fibromyalgia? For example, small fiber neuropathy, a condition which, if not excluded, will most likely affect your results. And he also asked if you need fibromyalgia patients to be referred by him.
Yeah, so I answered Alex's question in the chat box there. We are recruiting patients with fibromyalgia into our study at the moment. I'll paste I'll put the link in the chat there as well. It's a self-referral, so our eligibility criteria are on our website. Yeah, obviously part of the criteria is that you've been screened and diagnosed with fibromyalgia by an appropriate medical professional. Yeah, and in regards to the small fiber neuropathy, it's a very good question. There's lots of masqueraders for widespread chronic pains like fibromyalgia, and one of our criteria is that people coming through the study have been screened by more often than not a rheumatologist or a pain management consultant before they come through. Yeah.
And so it's specific to just that patient group because it's coming through official diagnoses. Yeah. Okay. In those trials, is there any screening for psychiatric comorbidities, or is that left out?
So we there are several aspects or layers to the screening, and I think just for consistency's sake with other trials, we're being consistent in that way. Yeah. There's a whole other discussion to be had about that, but I won't open that box right now.
Sure, yes. Maybe next year we could have a talk about the differences in how these diagnostic criteria are sometimes hard lines where people might teeter on the edge but not actually have the diagnosis, or be very close to not having, but they just fall over the line. I think that would be an interesting topic, especially in regards to psychedelic research, of what neurotypical actually is, if it exists.
If it exists.
Yes. But there's some more questions. I think the final one now that all of the panelists might like to chime in on is about the patient public involvement and how this type of research in the psychedelic realm might benefit more from learning from the underground because of how people have historically used psychedelics to treat their own pain. Do you think there could be avenues to increase support from patients or practitioners in the underground, or ways that information could be obtained a bit more easily or shared?
I think the above ground's been using the underground's research all along, not always crediting him anyway, because that's the best way to get the data under prohibition. My issue with that is that as regulations, at least in the United States, as states are deregulating psychedelics, the regulations that are being written often exclude home use, which is a problem for people in pain. The regulations that are also starting to be written in preparation for federal use in the states of psychedelics are being used with mental health and behavioral health in mind. The model where you go in to therapy, you get seen under therapists, and then you're released, which will not be great for people in pain. The way that we have traditionally assessed knowledge and evidence is by having scientists and professionals suss out what is true, what is good evidence, and what is not good evidence. My argument here is that professionals have not done their job well. Professionals have systematically excluded populations, non-white populations, marginalized populations, women, people in pain generally have been underserved for a very, very long time. And those people have had to go to great lengths to find treatment. I think there has to be a way of separating out people who have figured out good treatments for themselves from people who are just like on Google and like drinking bleach, to cure COVID. Like, there's embodied expertise, and then there's like just idiots. And I do think that the government can play a role there. There are ways that we can produce regulations around safety to make sure that people are ingesting the right that the psilocybin they're taking is psilocybin, right? There are like harm reduction ways that we can support citizen science, that citizen science can enjoy oversight as well. So those are things that I think have to be researched and developed, and that citizen science can be taken seriously without just stealing that knowledge and then denying people access.
Very good point there. The people who originally did the work, be them renowned and recognized or not, if it's a sound scientific method that's created some sort of plausible result that can be replicated, then of course it needs to be props given where they're due. It's 6:30 now GMT. So I'd like to say a really big thank you to all the panelists here today on the Psychedelics and Pain panel, the final panel of the Student Psychedelic Conference 2022. Jan Ramaekers, Joanna Kempner, Julia Bornemann, and James Close, thank you very much. It's been great to have you here and watch your presentations. And I again would like to say a big thank you to the rest of the Student Psychedelic Conference organizing team, James, Anna, Nadia, Dasha, Alex, Alkioni, Joanna, and Eddie, and Richard also. It's been a good time and a nice weekend. The event has gone well. So thank you all. Please do keep an eye on your emails. There'll be some links sent for feedback forms and contact forms where people can share their details. And we'd love to hear what you thought as participants about our conference this weekend, so we can make next year even better. So thank you all so much, and we'll see you soon.